piece of the call now, I want to concentrate on measuring your hospital 101. And I want to touch on what's listed on the slide on checklist use and using the checklist as a coaching tool to observe things, but also measuring your use of the checklist. I want to talk about ways of figuring out what it's doing about patient care. And then finally, I want to touch a little bit around questions people ask us all the time about measuring mortality and complication rates at their own hospital. Because I think that, one of the reasons why we encourage people to use the checklist is because we know it can do good things in a hospital, and people want to know, did it work in our place? So I'll touch on that just a little bit. So I want to talk to you about using the checklist to figure out where you are, and I think this tool I'm going to show you, you'll be able to see how it could be used that way, but also how to use this checklist coaching tool as a way to help people do better. So we think it's a pretty simple tool that an observer can use in the operating room to better understand how the teams are actually using the checklist in your hospital. And we think it can also help you provide feedback and then coach the team. And I'll show you some of the ways that you might want to do that. So this is the Surgical Safety Checklist Coaching Tool, and I'll admit from the very beginning that it looks maybe fairly intimidating. It is on one page, however, but it covers a lot of different areas of how the checklist might touch the work that you actually do in your hospital and how people are actually performing the checklist. So I want to take the Surgical Safety Coaching Tool, and I want to break it down for you into different areas to show you what it's really looking at. But from an overview, we can see that it touches on processes of care, and by that, it's pretty much focused on skip measures. Only what's different here, a lot of hospitals have gotten very good at skip measure documentation. This is all after skip measure performance. To make sure that what you think is happening is actually happening, so that's a piece of it, since most hospitals leave that on their checklist. And then you can see it has a briefing and debriefing section, just like the checklist. And then a place for you to look for what the buy-in looks like of the different people that are actually doing it. And then finally, down at the bottom, there's some additional data that we think can be helpful to people in understanding where they are. So I want to walk you through some of the sections over the next two slides. So it's broken. I took the checklist tool and I've taken a lot of the complicating information gathering pieces out of it so that we can concentrate on the processes of care and then the briefing and the debriefing and actually read through some of the questions to see the kind of feedback that we might get and how that might help you use this as a coaching tool. So one of the things that happens, I think, to everybody when they go in to coach, when you're done watching a team perform the checklist, you might have identified one or two things that they could have done better, and you also kind of have an understanding of how they did the whole thing. Kind of a gestalt, an overall summary impression of how the checklist went. But it's hard to hold all that in your head. And one of the ways that I think this kind of a tool can be helpful to you is it can let you keep track of what's happening while the checklist is actually being done in front of you, and then you can use that to give feedback. So standing now in the position of an observer or a coach, as the checklist is actually being done then, you can keep track using this form of what happened. And you can see the kind of things that we think are important. And some of them overlap heavily with what the Joint Commission now thinks is important about a timeout. Which of the following individuals participated in confirming the patient's identity, procedure, and operative site before incision? So this is really looking at, was the whole team engaged in the timeout? And by looking around the room and checking off, you can remind yourself to look at everybody and see if not only did they stop doing what they're doing, but are they actually involved into it. important thing for the Joint Commission, because we know if they come into your operating room and they see the surgical tech or the nurse who's scrubbed off doing something while everybody else is doing the timeout, they're not going to be very happy with the way that timeout was done, and you're likely to hear about it. Did team members introduce themselves by name and role? And obviously this is trying to get to that checklist prompt. And if it was no, what was the reason why it was no? Because sometimes you work with the same people every single day, introducing everybody by name and role isn't, it doesn't seem like a great thing to have to do, but probably at least once in the day, that should be a good thing, so this gives you an out there. Before skin incision, did the surgeon discuss the operative plan? This little piece, the next three questions, are really trying to find out, was the surgeon engaged? Did the surgeon say something? And did they say those things on the checklist that we think are really the most important for the surgeon to share? Now, I want to remind you all that how important this really is, and we actually know more about this now from some work that we've done up here in Boston. The surgeon who's the keeper of all this information, a lot of them, the reason why they push back here is they already know all this stuff, but the people around them don't. And I think you really want to know as you do this work in your hospital, do you have your surgeons actually engaged? And you can think you do, and then go and watch and find out that you really don't. Those three questions help you figure that out. Did the nurse discuss sterility, equipment, or any other concerns? Did the anesthesia provider discuss the anesthesia plan? And finally, were all checklist items read aloud without reliance on memory? And this whole little section then can give you a tremendous amount of feedback. Are people stopping? Are they engaged? Are the individuals who are supposed to be communicating actually communicating? And then finally, are they using the checklist like a checklist? The checklist isn't meant to be memorized. So that last question, question number 11, is an absolutely critical one, and it's one of the things that we see go away the fastest in hospitals after they're done with their implementation. So people will start and they'll use the checklist because they don't know the checklist and they need the checklist, or they perceive they need it more because they can't remember all the elements. But everyone is tempted after a month or 2 months or 3 months that now they know it all. And the problem is we never do. The more stress we're under, the more likely we are to forget some important checklist element. So that read aloud piece is really important. And it's important for you to know whether it's actually, you want it read aloud, or are they actually reading it aloud? Is the surgeon reading it off the checklist that's blown up on the wall big enough for his old eyes? Or has he taken upon himself to memorize it, only now he forgets all kinds of different pieces of it, and you're really not getting what you want. So that's how this tool can actually help you. And then finally, in the debriefing section, this lets you know whether the checklist is actually being done or not at this point in the case. Again, we know from the group of hospitals that went before you in the first webinar that this is probably the most challenging piece of the whole thing. The first piece for the anesthesiologist and the nurse when they go into the operating room, that's almost part of normal practice already. Maybe it makes it a little bit more, and hopefully it makes it more robust and there's more information sharing, but the barrier to putting that into place is usually pretty low. The timeout, thanks to the Joint Commission, actually that part of it in a lot of hospitals is done reasonably well. And we're trying with the checklist to make it even better, and this tool can show you that. But the debriefing isn't something that we're used to doing. The Joint Commission hasn't asked us to stop and do this. It's not a part of the normal end of a case. We think here that the best thing to do to remind yourself to do it is to hang it on something that you always do. And the most common always do at the end of a surgical procedure is the reporting of the sponge and instrument counts at the end of the case. That is a logical time to stop for 30 seconds or a minute and do this final section. And this tool then can give you feedback about whether people are actually doing that. So before the patient leaves the OR, did the team discuss specimen labeling? Now, I know because we talked about it when we went over the checklist together, everybody understands how incredibly important that is. And yet, if you don't already have a process that's focused on it, a lot of times it doesn't get done the way that it should. Did the team discuss equipment or other problems that arose? Again, the idea here is to fix the broken equipment if it needs to be fixed so it comes back to you the way that you want it in the very next case. And then finally, did the team actually verbalize and talk about plans for the patient's recovery and postoperative management? And I know when we talked about the checklist, we talked about why that's important. This is one of those transitions of care where we really want everybody to be on the same page. But another thing I want you to think about, since I have the excuse to remind you about it right now, is a lot of times the people that are actually in the OR don't know what you have planned, and they're just interested. I mean, this is a particularly important message for surgeons, and I know there aren't a whole lot of surgeons out there with me today, but the surgeons don't realize that the scrub nurse and the circulating nurse actually are interested in what happens to the patient after they leave the operating room, and this is a chance to actually let them in a little bit on that story. So the way that I would ask you to use this kind of tool for these parts of the checklist performance is to use it as a way to guide what you look at, and then you can reflect back on this when it comes time to actually coach the team. And you can use this to figure out the questions that you might want to ask when you want to help them improve at the end about how they might do better. Now there's two other sections that are on that form, and I want to show them to you because I think they're also important. So one of the things that we've tried to understand here in Boston at the School of Public Health, and I think that you want to understand about your own hospital, is are people really bought in? Because I think we all know there's a lot of different ways to do things like a checklist in the OR. And I think we've all now probably seen surgical teams that do it really well, take it seriously, and get out of it all that we want them to get out of it. At the same time, we've probably seen people who are just going through the motions, and they're not getting very much out of it. They're probably getting more out of it than nothing, but they're not getting very much out of it. And I think one of the things that you want to know as leaders on the implementation team is, where is our place in terms of how do people actually do it? And this section was our best attempt to try and figure out, are they taking it seriously or are they just going through the motions? So there's a set of questions at the bottom looking around the room at everybody. And then there's a set of questions right up at the top to who was actively participating. Did everybody participate the way that we want them to, from circulating nurse all the way to surgical technician, or was the burden falling really on just the circulator? Again, this is one of those times when I think you really want to understand deeply what's really going on. Not what you think is going on, or what you see in one case, but from a sampling of cases in your place, what's really going on, and do we have more to work on? Most places find they have more to work on. And then finally at the bottom in a little heading that we call additional data, there are some other markers here of potential problems that the checklist might have helped with, or that you might find interesting and valuable to take forward. Like, did the circulating nurse have to leave the operating room repeatedly to find instruments or equipment? Because we believe here that the number of times that that box will get checked yes is going to go down as you get better and better with the checklist. So it's a measure you can use to see, are you improving? Were instruments and equipment available and functioning throughout the case? And if they weren't, we want you to tell yourselves about it on the back of the form. Same kind of thing there. Was a potential error or omission averted by the checklist? And I'm going to show you a report that actually can give all of you a little feedback about what we saw across the state of South Carolina in preliminary results anyway. But I think that's important when it comes to motivating people around the checklist. If there was significant blood loss, was a type and cross sent, or were blood products available for the patient? If there was significant blood loss anticipated, was adequate IV access discussed and obtained? And then finally, if the expected duration of the operation was more than 2 hours, did we talk about antibiotic redosing? Now, we haven't focused a lot on that. There's a line on the South Carolina checklist that refers to that, and that question on there is the test around that. That may be something that you're working on at your own hospital, and this is actually, we think, a good way for you to follow that. So people ask us, well, how many of these should we do? And I think some of our philosophy around that has actually changed a little bit over time. I think in order to get a reasonable idea, even if you're a pretty small facility, you want to get probably a sample of at least 10 cases watched. And I'm going to tell you a little bit more about how to do that in a second, but somewhere around that number will tell you probably pretty well what's going on in your operating room. That's probably a pretty reasonable sample or snapshot. Much less than that, and you don't know if what you're seeing is the norm or what you're seeing is unusual. We want to, if you'll let us, look at these forms with you and would love for you to share that information back with us and have a way for you to do that we can talk about later or even talk about offline, because we can analyze all this data for you and then feed you back a report. We can give you observation data processed no matter how many you give us. But again, the more you do, the more accurate your snapshot is likely to be. And then this is how we suggest that you think about actually doing it. So put it in the hands of a coach, and the coach, as we've talked about, you might think about members of the implementation team actually being coaches. But we know in other places that the tool has been put in the hands of nurse educators to coach, nurse managers to coach, or quality improvement officers. We also believe that you can learn a lot if the only thing you can do is to periodically ask the circulating nurse to fill this out in their own case. Now, there are advantages and disadvantages to whether you pick an outside observer or an inside observer, obviously. None of us are dumb or stupid, and we know that the bias is likely to be higher if we're asked to rate our own buy-in and rate our own behavior. We're more likely to overrate ourselves because we're all above average, and we know that. But practical constraints may make it that the best person actually might be to have a circulating nurse to do that, and then you can do whatever you want with the buy-in. But the rest of the information on that tool is likely to be pretty accurate in the hands of a circulating nurse. At a minimum, and another question that comes up is how long does the person who's observing need to be in the case? Now, if it's a circulator, a lot of times they'll be there for the entire case, and they can fill the whole form out. But the tool can be valuable even if you can't be there for the whole case, even if the only part that you can observe is the beginning part. If they could pass the tool to somebody else to do the end, that would be great too. But just learning about the front end even can be more information than you have right now. We recommend that you limit the number of people that are performing the observations so you at least get consistent feedback. Now, for that, I'm talking more about the people who are going to coach. And I think you already know, and I already know, that you're not going to have anybody go into the operating room to coach. You're going to pick those people, you're going to work with them, you're going to help them understand what you think is important about coaching. That's already going to limit that pool. But obviously, if every single observation is performed by a bunch of different people, you're less likely to get consistent feedback from what they actually see. So, we're committed up here to give you feedback based on those forms. So if you can send it to us, the tool is filled out, up here, we'll be happy to give you a report, and we actually can show you a report. I'm not going to do it today, but we can show you a report of how your hospital is actually doing along all those different questions. So question by question report, what did they see, yes or no, and then percentages and places where you're strong and places where we think you're weak, and sometimes we can even suggest things that you might think about. Most of the people that have gotten the reports back think that they've been very helpful to them, and we don't want to charge anybody anything for it. We're learning a ton from anybody who sends these to us, and that's enough for us, but we think it could be helpful to you as well. We recommend that everybody use the tools no matter what, whether you're going to send them to us or not, because we think even if you compile the data yourself, that's way better than not doing anything at all and not knowing what reality is. But we would love to help if you would let us actually do that.